Welcome back to The Deep Dive. Today we are taking on a document that is, well, it's universally acknowledged as the definitive blueprint for fixing modern healthcare.
It really is.
We're talking about the landmark 2001 Institute of Medicine report, Crossing the Quality Chasm, a new health system for the 21st century. And this is not light reading, but it's absolutely foundational.
It truly is. This report is essential because it moved the conversation beyond just looking at isolated problems and offered a systemic diagnosis. Our mission today is to analyze exactly how this IOM committee, and you have to remember, this was composed of leading experts, clinicians, policymakers.
And heavy hitters.
All of them.
Yeah.
And they concluded that the American healthcare delivery system required nothing less than a fundamental change. They didn't just suggest tweaks. They laid out a complete strategy for redesigning the system from the ground up for the modern era.
And to really grasp the gravity of the Quality Chasm report in 2001, you have to rewind just 2 years earlier. That's when the same committee released its first absolutely shocking report, To Err is Human, Building a Safer Health System.
Yeah.
That initial report was a massive wake-up call.
A huge one.
It revealed that tens of thousands of Americans, some estimates went as high as 98,000, were dying every single year from preventable medical errors. It was a real gut punch that forced the country to confront these massive safety failures.
That's right. To Err is Human really set the stage, but the 2001 Quality Chasm report immediately showed that safety, while desperately urgent, was only, and this is a quote, a small part of the unfolding story.
Wow.
The committee realized the defects were far more insidious and widespread. They weren't just causing direct harm, they were manifesting as this profound, deep-seated frustration. And not just among patients struggling to navigate the system, but also among the dedicated clinicians who are trying to treat them.
So the core thesis the report offered was just devastating. It said the system harms too frequently and routinely fails to deliver its potential benefits. It's a total indictment of reliability.
It is.
But here's the almost unbelievable irony here. This profound systemic failure was unfolding during a period of just unprecedented scientific and technological flourishing in medicine.
It's that contrast that makes the report so compelling. The source material highlights this stark disparity. You had science sprinting ahead while the delivery system was basically standing still.
Right.
Look at the investment figures leading up to 2001. Between 1993 and 1999, the budget for the National Institutes of Health, the NIH, it jumped substantially.
Yeah.
We're talking from $10.9 billion to $15.6 billion. That's a huge public investment in knowledge.
And private investment was right there with it, mirroring that growth. Pharmaceutical firms essentially doubled their investment in R&D, going from $12 billion to $24 billion in that same time frame. We were seeing these revolutionary advances.
Oh, absolutely.
Genomics was moving from theory into actual practice. Miniaturized devices were becoming possible. New drugs were hitting the market faster than ever. We had the knowledge to significantly increase longevity and functioning.
Exactly. The scientific potential was boundless, but the delivery system was just tripping over its own feet. The report uses this very specific word. The system has floundered in its ability to translate all that new scientific knowledge, all that massive R&D investment into consistently high-quality care for the average patient.
So it was failing to apply new tech safely.
Failing to apply it safely, failing to apply it appropriately, and leaving millions of Americans without the effective care they should have been getting.
So the committee wasn't just observing a current flaw. It sounds like they were predicting a coming catastrophe. If the delivery system couldn't consistently handle the science of 2001, they concluded it was catastrophically ill-prepared for the extraordinary, exponential advances that were sure to come in the 21st century.
And that elevates the report's mission. This wasn't just about making care a little safer or a little more efficient. It was about ensuring the entire healthcare enterprise could function at all in a future defined by radical complexity and just a richness of knowledge. They were looking at this fundamental gap between what medicine knew and what it could reliably do.
Okay, let's unpack this further. Why exactly was the system failing so spectacularly? The report doesn't just blame incompetence. It isolates these 4 fundamental structural factors that conspire to create this quality chasm, that huge, potentially deadly gap between medical potential and the reality on the ground.
Right, and the first factor is just the sheer overwhelming scale of the growing complexity of science and technology. Think about what the average clinician faces today, or even back then. The source's note there is simply more to know, more to manage, more to watch.
It's a cognitive overload.
Completely. The pace of scientific advance is now faster than our ability to safely and efficiently integrate it into clinical practice.
I think the report noted that the average number of new drugs approved annually had doubled since the early 1980s. That's a staggering cognitive load. It's not just memorizing the names, it's understanding the complex interactions, the contraindications, the personalized dosage
You
requirements.
can't rely on human memory alone anymore. It's impossible.
Right. The system was just ill-equipped to handle cutting-edge advances, like the coming wave of genomics or integrating miniaturized devices.
And that cognitive challenge is immediately compounded by the second factor, the dramatic increase in chronic conditions. So advances in medicine are extending lifespans, which is fantastic, of course. The average American was expecting to live over 76 years. But this means the population is older and, crucially, sicker with long-term complex conditions.
So we're shifting from an acute care model.
A total shift. Away from treating a broken leg or an infection to a chronic care model.
And the numbers on this are just dramatic. The report points out that nearly 70% of personal health care expenditures in 1990 were already devoted to chronic diseases. The system that was designed for these rapid response acute episodes is now spending the vast majority of its resources on long-term management that requires continuous coordination.
And the complexity just explodes when you factor in comorbidity. If a patient has just one chronic condition, their average annual medical cost around that time was about $1,829. But if they have multiple chronic conditions,
Yeah, it's not just double.
not even close, it jumps dramatically to $4,672. Managing hypertension, diabetes, and arthritis all at the same time requires not just more resources, but integrated, continuous, tailored care that the acute care-focused system was structurally incapable of providing.
And that leads directly to the third factor, which is a poorly organized delivery system. When the IOM interviewed patients for this, they frequently described the system as a nightmare to navigate.
It felt less like a coordinated system and more like a,
Yeah.
the quote was a confusing, expensive, unreliable, and often impersonal disarray.
Which is just a damning description.
It is. And think about the care process itself. It was characterized by massive complexity, unnecessary duplication of services, and these frustrating, sometimes harmful delays. The classic example is the handoff failure.
So when a patient moves between providers,
Exactly. A patient might see a primary care doctor, then a specialist, get admitted to a hospital, and then be discharged to a rehab center. If there's information loss, a test result, an allergy notation, a complex medication schedule, at any of those organizational boundaries, the patient's safety is immediately compromised.
that fragmentation is not just irritating paperwork, it is fundamentally unsafe and, I imagine, extraordinarily expensive because of all the redundant testing.
Exactly. And none of this complexity or fragmentation could be solved without addressing the fourth major structural factor, constraints on information technology.
Right.
This is where the committee delivered that truly fantastic analogy. They said healthcare was trying to deliver modern technologies, genomics, advanced imaging using today's medical production capabilities. They likened it to the medical equivalent of manufacturing microprocessors in a vacuum tube factory.
Wow. That paints such a vivid picture of these antiquated manual processes trying to manage exponential digital data. So why was automation so slow?
The report isolates two key reasons. First, huge public concern over the privacy and confidentiality of digitized health data, which was an entirely legitimate fear. And second, a fundamental lack of national standards for data capture, storage, and communication.
So everyone was building their own little digital island and none of them could talk to each other?
Precisely. Technology is the single greatest tool for managing the knowledge complexity, the chronic care burden, and the coordination problem. But in 2001, the necessary standardized digital infrastructure simply didn't exist to support it fully. And that paralyzed innovation at the system level.
So fragmentation and IT limitations created the gap. But how did the IOM measure exactly what was falling into that quality chasm? They adopted a formal framework to categorize these quality defects, right?
They did. They grounded their analysis in Donna Bedian's classic quality assessment model, which looks at structure, process, and outcomes.
Can you break that down?
Sure. Structure is the setting, the facility, the staffing levels. Process is what you do, the specific clinical actions taken. And outcome is what happens to the patient. The IOM used three categories to define failure in the process of care: underuse, overuse, and misuse.
Okay, let's start with underuse. This sounds like a critical failure. Not providing a beneficial service when the science says you should.
It is. It means the system fails to apply known science. And the examples are truly staggering, especially since these were all evidence-based interventions. Take cardiac care. A study of Medicare patients eligible for beta blockers after a heart attack found that only 21% actually received them within 90 days of discharge.
Only 1 in 5. And why does that matter?
Because the adjusted mortality rate for those who received the treatment was 43% lower than for those who did not. This is inexpensive, life-saving, evidence-based care that the system failed to deliver 4 out of 5 times. It's a massive failure of process.
Or look at basic prevention, which should be the easiest thing to standardize. Despite clear recommendations that people 65 and older should get a one-time pneumococcal vaccine for pneumonia, a potentially fatal disease in that age group studies showed that only 28% to 36% of the elderly population actually got it.
It's a collective failure in preventative care that directly impacts longevity and quality of life. Just a breakdown in simple, effective processes.
Okay, so that's underuse. The second category is overuse. This is the opposite failure, right?
Exactly. It's providing a service where the potential risk outweighs the potential benefit. It is medically inappropriate, it's wasteful, and it's often harmful.
And this would be things like unnecessary surgery.
That's a big one. Everything from performing a major surgery, like an unnecessary hysterectomy or a coronary artery bypass graft without appropriate clinical reasons, to the routine, widespread provision of antibiotics for viral infections, like the common cold.
Which don't work on viruses.
Not only are they completely ineffective, but this overuse directly accelerates the global crisis of antibiotic resistance, which damages public health for everyone. They also highlighted the inappropriate insertion of ear tubes in children when it wasn't clinically indicated. Overuse is a major driver of expense.
Right, because it's not just the risk of the procedure itself, it's draining resources, staff time, equipment, money that could be used to fix the dangerous underuse failures we just talked about.
Perfectly said. And finally, we have misuse. This category describes when the appropriate service is provided, but in a preventable manner that causes complications or errors. This is the failure that links directly back to the safety crisis highlighted in Self, to err is human.
So this is where process breaks down.
Yes. Misuse occurs when the process breaks down and turns a good intention into harm. Classic examples include prescribing an antibiotic to a patient despite a documented allergy that's visible in their chart, or providing an incorrect dose or dosing schedule. It highlights the failure of the system's design, its structure, and process to prevent predictable human error. A reliable, high-quality system has to be designed to catch and prevent those errors before they can ever reach the patient.
Okay, let's zoom out. The report did not stop at just describing the problems. It set a clear, strategic national agenda for what success should look like. To fix this chasm between potential and reality, the entire system needed a kind of philosophical North Star. And the IOM provided this with the shared agenda of the 6 aims for improvement.
Right. And these 6 aims, often conveniently remembered by the acronym SEEPTEE, they essentially define what quality means for the 21st century. If you can achieve all 6, you've crossed the chasm.
So starting with the first, safe. This was the original impetus for the committee's work, avoiding injuries to patients from the very care that's intended to help them. This requires not just better procedures, but a fundamental shift in institutional culture.
Exactly. A shift away from blaming the individual clinician for an error, that old shame and blame culture, and toward tracking, analyzing, and interpreting those errors to identify where the system failed. Safety fundamentally emerges from systems that are designed skillfully, using principles like standardization and simplifying complex tasks, rather than just relying on heroic efforts by individual staff members.
Next up is effective. This is the aim that tackles underuse and overuse directly.
That's right. It means providing services based on scientific knowledge to all who can benefit, which is the opposite of underuse, and refraining from services for those not likely to benefit, the opposite of overuse. This explicitly links the definition of quality to evidence-based practice and sound research.
Third, and this seems central to the redesign, is patient-centered. This feels like a profound shift in power dynamics.
It is. It means providing care that is respectful of and responsive to individual preferences, needs, and values, and ensuring that the patient's values truly guide all clinical decisions. The committee recognized that modern patients are informed, they want transparency, and they demand involvement in their own care planning.
Fourth is timely. Simple to state, but incredibly complex to achieve, reducing waits and harmful delays for both patients and clinicians.
And those delays are not just frustrating, they can be profoundly dangerous. Think about the patient waiting weeks for a critical diagnostic test, or the surgical team waiting hours for necessary equipment. Time is absolutely a critical dimension of quality.
The fifth aim is efficient. This is the financial dimension. It means actively avoiding waste.
Yes, and that includes waste of equipment, supplies, ideas, and energy. The sheer abundance of waste in the fragmented system, from duplicative tests to unnecessary procedures, is the opposite of efficiency. Many of the quality improvements the report suggests, particularly those correcting overuse and misuse, directly result in massive resource savings.
And finally, equitable. Providing care that does not vary in quality because of personal characteristics like gender, ethnicity, geographic location, or socioeconomic status.
The system has to treat everyone fairly and reliably, ensuring service availability is based only on clinical need, not on who you are or where you live. A system that achieves major, measurable gains across all 6 of these aims would be fundamentally transformed. It would be safer, more reliable, perfectly integrated, continuously available, and truly centered on the individual patient.
And to really drive home the necessity of achieving these 6 aims, the report uses 2 incredibly compelling patient case studies to illustrate the chasm. We have the tragic reality of the current system represented by Ms. Martinez in January 2000, and then the empowering vision for the future of Maureen in January 2002. Let's look closely at that contrast.
Ms. Martinez's story is a textbook example of fragmentation and failure. She was a divorced working mother in her early 50s with excellent insurance, but she had just moved to a new town. Her experience was just a cascade of failures, starting with a lack of equity and access.
So she couldn't even get in the door.
She struggled immediately to find a primary care physician. The first 2 offices she called weren't accepting new patients. She had to just settle for a practice she knew nothing about, purely based on who would see her.
Then the system failed her on safety and timeliness. She wasn't informed of an earlier abnormal mammogram result that was on file, which means a significant, frightening delay elapsed before the abnormality was even addressed.
And when she finally got a new mammogram, the appointment was 6 weeks out. Then when that result came back abnormal, the first opening she could get with a surgeon for a biopsy consultation was 9 weeks later.
9 weeks. That is just unforgivable.
Imagine the emotional toll. She described weeks of extreme anxiety, sleeplessness, constantly wondering what the diagnosis meant for her children, her job, her life. This illustrates a severe lack of patient-centeredness. Her profound discomfort, her fear, her uncertainty, they were never adequately addressed. She received very little assistance in understanding her complex treatment options.
And even when she went in for the procedure, the failure continued. Crucial lab information was missing from her records, and staff had to scramble to track it down just to avoid canceling the operation at the last minute. So despite having good insurance and being seen by capable clinicians, the system failed her fundamentally on timeliness, safety, and continuity.
Now contrast that traumatic experience with Maureen, the vision of the ideal redesigned system in the same circumstances. A single working mother, new in town, in January of 2002.
Her experience started completely differently. She had immediate online access to physician profiles, including detailed information on office hours, credentials, patient satisfaction scores, even public outcomes data. This allowed her to make an informed, equitable choice that was tailored to her needs as a working parent.
And the system was immediately timely and coordinated. Since she was due for a mammogram, her new physician digitally attached a referral to her reply message. She was able to schedule the mammogram online for a convenient time. The report specifies a Sunday afternoon, which illustrates the liberation from that old 9-to-5 care model.
And here is the crucial difference. The results and the required follow-up, the biopsy confirmation, were available before she left the breast care center.
That's the game changer.
Right. That immediate feedback eliminates the weeks of debilitating anxiety that Mrs. Martinez was forced to endure.
And the coordination ensured the care was both effective and patient-centered. Her primary care physician used an open scheduling system to see her the very next morning to evaluate her newly diagnosed hypertension before starting her breast treatment. This proactive coordination ensured that one condition didn't destabilize the treatment of the other.
Furthermore, she was empowered with information under this new model. She could read her own records, communicate with her care team via secure email, and was even linked with other patients who had faced similar choices for decision support. As the report summarizes it, she experienced no paperwork to complete, no duplicative questions, and no trouble reaching professionals. That is the tangible human definition of what it means to cross the quality chasm.
So if we connect this to the bigger picture, achieving those 6 aims, safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity, it requires more than just new technology. It requires a total philosophical shift in how medicine is organized and delivered.
A new operating system.
Exactly. This is the new operating system for healthcare, and it's guided by the report's 10 simple rules.
The committee emphasizes that these rules are essential because the traditional 20th century assumptions about medical practice just no longer hold true in the face of scientific complexity and the epidemic of chronic disease. It's a complete overhaul of the social contract between the patient and the provider.
Let's start with the revolutionary change in access. Rule 1. Continuous healing relationships. The old assumption was that care was based strictly on scheduled visits, typically confined to narrow 8 a.m. to 5 p.m. office hours. The new rule mandates continuous access, 24/7/365.
The report uses a very powerful analogy here, citing the banking industry. Just as customers were liberated from physically going to a teller during restricted banking hours, technology should liberate patient care from the confinement of the face-to-face visit.
Right. This means secure email, patient portals, and the internet substituting for many unnecessary or routine visits, making care safer, timelier, and far more efficient. It shifts the relationship from these transactional encounters to continuous management.
This continuity is tightly linked to Rule 3, the patient as the source of control. Traditionally, the control over clinical decisions, access to information, scheduling, it resided almost entirely with the professional caregivers.
It was yielded to the patient only at the clinician's choosing. The new rule asserts that control must now reside with the patient, except in truly unusual or emergency circumstances.
This fundamentally flips the power dynamic. It mandates that patients must have unfettered access to their own medical records, including lab results and diagnostic images, as soon as they're available. It demands that providers use interactive systems for shared decision-making, helping patients integrate their own lifestyle, personal beliefs, and tolerance for risk into the treatment planning process.
It moves us away from that old authoritarian doctor knows best model.
Right, and that idea of shared authority leads directly to Rule 4, shared knowledge and the free flow of information. The old model operated under a need-to-know basis, severely limiting access to information to only the clinicians involved.
The new rule demands that clinicians and patients must communicate effectively and share information freely across all organizational boundaries.
But Rule 4 also highlights a complex structural challenge that's still relevant today: the question of who owns the health information. While laws exist to grant patients access, the practical resistance from some organizations to provide those records can be immense.
Right. And the IOM stressed the importance of transparency here, recommending that patients should be able to see an audit log, a precise list of everyone who has viewed their identifiable data to build trust and ensure privacy.
Moving to clinical consistency, we have Rule 6, standardization to excellence. The 20th century system was characterized by enormous, unwarranted, and unpredictable variation in care.
The new rule dictates that standardization must occur for the vast majority. Think 80% of patient needs, utilizing the best available clinical evidence.
Now, this is crucial. Standardization is not a punitive measure, nor does it mean one size fits all. The report clarifies that modern IT systems allow complex protocols to incorporate patient-specific variations like kidney function, other chronic diseases, or known allergies. The standardization targets the process of delivery, ensuring that the 80% of routine work is done reliably, not the person.
And to illustrate the sheer impact of enforcing standardization, the report points at LDS Hospital in Salt Lake City and their work on adult respiratory distress syndrome, or ARDS. In the 1970s, ARDS had a horrifying mortality rate of close to 90% in the ICU.
Unbelievable.
And the treatment was highly complex and varied wildly among clinicians.
So by the 1980s, LDS Hospital developed a computer-generated guideline for concurrent management of ARDS. This protocol incorporated several thousand separate instructions, far too many for any human doctor to remember and apply consistently.
The system didn't replace the doctor, but enforced systematic, evidence-based care in real time by demanding responses from ICU staff.
And the results?
The results were dramatic and industry-changing. By 1991, they reported a survival rate of 45%, and some later investigators achieved rates as high as 75%. This showcases the immense power of standardization, taking complex life-or-death situations and applying consistent evidence-based protocols that reduce the chance of human error and maximize effective outcomes.
We must also look at Rule 8, anticipation of needs, which represents a complete break from the traditional methodology of simply reacting to events or crisis management.
Consider the common scenario of Pearl Clayton, an 86-year-old widow who is forgetful, grieving, and prone to falls. In the reactive system, her family and providers procrastinate. She eventually falls, fractures her hip, and is rushed to the hospital.
So her complex underlying problems, grief, misuse of sleeping pills, alcohol, are managed only as an acute hip fracture crisis in a costly setting.
Exactly. But under the new rule, anticipatory management shifts the focus. Proactive mental status evaluations and routine home visits identify her cognitive and emotional problems before the fall and hip fracture happen. Even if hospitalization is eventually needed, clinicians have her accurate history and can anticipate issues like withdrawal symptoms, using standardized protocols to avoid complications like aspiration. The system moves from reacting expensively to proactively managing potential problems cheaply and safely.
And finally, a key behavioral change is defined in Rule 10, cooperation among clinicians. The old system often prioritized professional prerogative and rigid role definition. A clinician's rigid role often trumped the efficiency and safety needs of the system.
The new focus is on good communication, mutual respect, and leveraging the expertise of the multidisciplinary team.
So this means enabling non-physician staff to take on expanded, sophisticated tasks. The sources describe intensive care units where respiratory therapists, when properly trained and empowered, are essential members of the team.
They might confidently tell an admitting doctor that a patient isn't ready to have a ventilator tube removed, or they can autonomously adjust ventilator settings within predefined physiological parameters. By cross-training and empowering these team members, organizations become much more responsive and efficient. Nurses may start wavies. Pharmacists become integral parts of the patient-rounding team.
It breaks down those professional silos.
It does, and that leads to fewer errors and faster processes, fully utilizing the entire workforce's expertise.
Now, setting these philosophical rules is one thing, but implementing them across a massive, fragmented sector is another. To achieve them, healthcare needed to stop viewing itself as unique and adopt robust engineering principles from high-performing service and manufacturing industries. This must have been a massive aha moment for health leaders reading the report.
It was, because healthcare often views itself as too complex or too human to follow standardized industrial logic. But the IOM argued that the complexity of medicine actually demands systems thinking. One core principle they advocated was system design using the 80-20 principle, or the Pareto principle.
The traditional way was to build overly cautious, cumbersome systems designed to accommodate all possible occurrences, the rare edge cases, which inevitably slowed down the 80% of routine work. The 80-20 rule, applied here, recognizes that approximately 20% of patient types or causes are responsible for 80% of the work, complications, and costs.
Therefore, you design standardized, explicit, streamlined processes for the usual case, the 80% of work that is routine, and you create dedicated, resource-intensive contingency plans for the remaining 20% of complex, unusual cases. This approach focuses efficiency gains where they are most abundant and prevents the typical case from being bogged down by rules designed for exceptions.
A second imported principle is mass customization. This is the art of combining the uniqueness of customized services, which patients demand, with the efficiencies and low cost of mass production, which the system requires.
In a healthcare setting, this is achieved by classifying or categorizing patients, perhaps by severity of illness or risk level, to standardized core modules of service delivery. For example, a hospital standardizes core modules like the admission process, the family education materials, or post-discharge medication reconciliation.
Then, drawing on the analogy of a computer company like Gateway, which uses standard modules like a hard drive or memory to quickly and affordably customize a laptop, healthcare can tailor the remaining aspects, the rehab plan, the specific home care services, to individual preferences, all built upon a foundation of efficient, standardized core modules.
And finally, continuous flow. This principle focuses on eliminating the painful delays and batch processing that characterizes so much of the current fragmented system.
Historically, practices would batch tasks. The doctor would dictate all their notes at the end of the day. The nurse would return all phone calls during a specific hour. This created massive backlogs, repeated calls from patients, delayed medication management, and increased anxiety. The opposite is continuous flow.
The best example is open access scheduling systems, where the goal is for patients to be seen the same day they call, if they wish. This radically reduces the 2-week waits typical for non-urgent appointments, which often cause high no-show rates and force patients into expensive emergency care.
We saw in one primary care center that implemented this that the total number of patient visits actually declined by 7%, and the no-show rate went from a costly 20% to too small to show up in the statistics because patients could get all their needs met in a single timely visit. Continuous flow proved to be both immensely patient-centered and far more efficient.
Moving from the philosophy of the new rules to the practical execution, the committee recognized that achieving this complete system redesign required major infrastructural changes across four key pillars and, crucially, the upfront funding to support it.
Let's discuss Pillar 1, Priority Conditions and the Innovation Fund. The sheer magnitude of the required change meant they couldn't possibly start everywhere at once, nor should they. National leadership was needed to focus the initial efforts where the impact would be greatest.
Their recommendation was for the Agency for Healthcare Research and Quality, or AHRQ, to identify at least 15 priority conditions. These needed to meet three criteria: affect large populations, account for a sizable health burden, and consume significant resources. This focuses reorganization efforts where the most good could be done for the most people.
And the list they identified from the Medical Expenditure Panel survey was essentially the map of chronic America: cancer, diabetes, emphysema, high cholesterol, hypertension, ischemic heart disease, stroke, arthritis, asthma, and depression anxiety disorders.
Right. The strategy was to reorganize care around the patient's total health needs for these conditions, rather than forcing the patient to navigate dozens of different physician specialties or institutional boundaries.
And critically, to seed this massive reorganization, they proposed creating a healthcare quality innovation fund. This wasn't supposed to be a massive chunk of money in the grand scheme, around $1 billion over 3 to 5 years, which was about 0.25% of federal health spending at the time.
And the reason this specific public funding was necessary was because the committee noted that organizational redesign changing processes, changing culture, historically received almost zero investment compared to the billions poured into new drugs and technology. This fund was needed to provide seed money for the upfront costs of redesign projects and, crucially, to ensure the information gained from these successful pilot projects became a public good, rapidly disseminated to the rest of the field.
We can see the power of that seed project concept in the case study provided on an emergency department redesign. This ED wanted to radically reduce patient cycle time, a core failure of timeliness and efficiency. They introduced real-time tracking systems, their own custom-built radar screen, and implemented parallel processing.
Which means multiple tasks like drawing blood and taking a history happen simultaneously instead of one after the other.
Exactly. And the results were staggering evidence of what engineering principles can achieve in a clinical setting. For less urgent patients, the total cycle time was cut almost in half, from 92 minutes to 47 minutes. But for critical patients needing admission, the time from the decision to admit to actually getting them into a floor bed dropped from 210 minutes, that's 3.5 painful hours, down to a mere 60 minutes.
That type of radical improvement, which required upfront investment in systems and training, is only possible through dedicated system-level engineering.
Now on to Pillar 2. Information technology, the great enabler. We already established IT was the biggest barrier, but the report makes clear it also the central enabler for achieving all 6 aims.
Without robust IT, you can't be safe. You don't have computerized physician order entry, which prevents dosing errors. You can't be effective. You don't have automated reminders for evidence-based guidelines. You can't be timely, no immediate access to records. The central function is the automation of patient-specific clinical information, which means achieving universal, functional electronic medical records and interoperability between them.
The major challenge here was the historical failure to develop common standards for coding and transferring data. The committee saw the Internet, with its standardized open technology protocols like TCP/IP and HTTP, as essential for overcoming these organizational and technological barriers. It could provide the universal connectivity necessary to support decision support tools and shared records.
And while the DHHS privacy and confidentiality regulations were finalized in December 2000, a controversial but necessary step, they were seen as laying the groundwork. Establishing those national standards for protecting patient data was deemed necessary to establish the trust and framework required to fully digitize the system and enable connectivity across historically siloed organizations. You need security before you can have true shared knowledge.
This brings us to Pillar 3, payment alignment. This is perhaps the trickiest obstacle because it involves fixing the fundamental financial misalignment. If we don't fix how money flows, none of the other changes are sustainable.
This raises the most important question in healthcare economics. How do we fix the fundamental misalignment where quality improvement can actually lead to financial losses for the provider.
The perverse incentives.
Powerfully perverse incentives, especially in fee-for-service and per-case payment models like DRGs or diagnosis-related groups.
Let's break down those perverse incentives using the IOM's 3 categories of quality failure. If a physician under the fee-for-service model works to reduce overuse, say performing fewer unnecessary tests or procedures, what happens to their revenue?
It drops. They are financially penalized for doing the right thing, the efficient thing, the safe thing.
And conversely, reducing misuse, for example, reducing preventable complications in a hospital setting, can also lead to severe financial loss for the institution under the DRG system. The report gives the chilling Utah pneumonia example. The hospital implemented better, standardized guidelines and reduced the rate of complications, leading to fewer patients needing high-cost interventions like ventilator support.
The financial mechanism is just stark. When a patient with pneumonia requires ventilator support, they're classified under a high-paying DRG, which might pay the hospital, say, $16,500. But if the new quality initiative prevents that complication, the patient shifts to a much lower-paying DRG for simple pneumonia, which pays only $4,730.
So the quality improvement was undeniable. Fewer complications, likely fewer deaths, better patient outcomes. But the hospital's finance department calculated that this success led to a net operating income loss of over $200,000 annually.
They were being financially penalized for better care. The structure rewards inefficiency and complications.
The committee concluded that no payment method is neutral. They all impact provider revenues. Under the prevailing systems, correcting underuse tends to bring financial gain, but correcting overuse and misuse resulted in devastating financial penalties, making sustained quality improvement structurally impossible.
Therefore, the committee's recommendation was firm. Purchasers, meaning government payers like Medicare and Medicaid and private insurers, must re-examine payment policies to remove these perverse barriers. They must build stronger incentives, provide fair payment that is adjusted for patient risk, and crucially, allow providers to share in the economic benefits of quality improvement.
They specifically highlighted the pervasive issue of the risk selection problem. Imagine a health plan dedicates significant resources to developing an excellent, proactive chronic care program for patients with diabetes. If they succeed, they become known for their high quality of diabetes care.
That success means they attract sicker, higher-cost diabetic patients away from less effective plans, a process known as adverse selection. If the payments the health plan receives are not adjusted for the higher health risk of this sicker patient pool, the financial burden of their own quality improvements falls entirely on them.
Which creates a powerful disincentive to invest in quality programs in the first place.
Absolutely. This emphasizes the absolute need for sophisticated risk adjustment methods, such as those using adjusted clinical groups or diagnostic cost groups. These methods use clinical data, not just simple demographics, to accurately predict future medical costs and ensure fair compensation regardless of the severity of the illness a plan attracts. If you don't risk adjust, quality improvement is financially dangerous.
Finally, we turn to Pillar 4, preparing the workforce. All these redesigned processes, standardized protocols, and IT systems are useless if the people running them aren't trained for the 21st century model of continuous coordinated care.
Right. Clinicians needed a fundamentally different skill set than traditional acute care training provided. The new required skills include the ability to work collaboratively in multidisciplinary teams, the capacity to rapidly synthesize complex evidence and communicate it clearly to patients, proficiency in using decision support systems, and a deep understanding of the patient experience outside the hospital setting. They needed to master basic safety design principles like standardization and simplification.
However, implementing this curriculum change is hampered by severe structural barriers. The complexity of clinical education oversight is immense. You have dozens of separate, often competing bodies regulating medicine, nursing, pharmacy, and other specialties. This diffusion of responsibility and authority makes fundamental, coordinated curriculum change excruciatingly difficult and slow.
And we can't ignore the paralyzing issue of regulation and liability. State-level scope of practice laws must be coordinated to allow new types of providers, like the empowered respiratory therapists we discussed, to function effectively in the new multidisciplinary team environment.
More critically, liability issues pose a direct threat to innovation. If a clinical team begins using new evidence-based processes, say, using secure email consultations for routine follow-ups or non-physician staff managing ventilator settings, those new processes often deviate from what is considered the long-established standard practice.
So if something goes wrong, the innovation itself increases the threat of litigation. The legal system relies on defining standard practice in the relevant medical community. If the courts and liability insurers fail to rapidly incorporate evidence-based thinking, clinicians and organizations face a powerful conflict. Adhere to outdated practices to reduce liability risk, or adopt safe, effective new practices and potentially increase legal exposure. That fear can absolutely inhibit the very innovation the system desperately needs.
Okay, here's where it gets really interesting and perhaps most philosophical. After laying out the profound problems, the goals, the 10 rules, and the necessary infrastructure, the IOM strategic plan for this massive shift isn't about creating a monolithic, top-down command and control system. It's about leveraging complexity theory to let the system organoid itself.
That's it. They stress that healthcare must be understood through the lens of complexity science. Healthcare is not a machine where behavior is predictable and must be imposed by rigid, detailed blueprints. It is instead a complex adaptive system, or a CAS.
What's the defining difference between a machine and a CAS in this context?
Well, a machine works predictably as long as the inputs are the same. A CAS is composed of adaptable elements like physicians who learn, or antibiotic-resistant organisms that evolve. It exhibits nonlinearity, meaning small changes in one part of the system can have large, unpredictable results elsewhere.
And it has emergent behavior.
Exactly. Continual creativity and inherent order without central, autocratic control, a property known as self-organization.
That's a huge psychological shift for an industry accustomed to rigid hierarchies. If you are building a mechanical system, you need a complex blueprint to achieve a complex outcome. But the IOM committee argued that in a CAS, complex stage 4 quality outcomes can emerge naturally from a few simple rules that are applied consistently at the local level.
This concept is demonstrated outside of medicine by massive global systems. Think of the architecture of the internet, which operates under simple rules like HTML and basic naming conventions, but allows for near infinite, unpredictable creativity and connection. Or the credit card system, Visa, which manages a multi-trillion-dollar global business with very little central micromanagement, governed by simple rules regarding standardization and security.
So the design challenge was explicitly not to spend years agonizing over a perfectly detailed national blueprint. Instead, the strategy was to generate a good enough plan based on those 10 simple rules and the 6 aims, and then start observing, allowing modifications to occur in an evolutionary, self-organizing fashion. This decentralized approach liberates innovators at the local hospital or practice level.
It's about providing the conditions, the common purpose defined by the 6 aims and the simple rules under which massive and diverse local experimentation can happen. Then, the system must rapidly identify and disseminate the best, most fit ideas, the innovations that actually improve safety and efficiency.
And that ties us back perfectly to the original definition of quality. The IOM's comprehensive report laid the foundation, linking structure, process, and outcomes to the core definition, the degree to which health services increase the likelihood of desired health outcomes and are consistent with current professional knowledge.
We've thoroughly established that quality improvement requires a significant, expensive investment up front in IT, in training, in redesign. However, the costs of poor quality, the waste, the duplication, the errors, the complications, and the immense human toll are absolutely enormous and fundamentally outstrip the cost of the required infrastructure shift.
So what does this all mean for the immediate path forward? The ultimate measure of quality involves not just assessing the structure or the process, but the patient outcome. And as we detailed earlier, the Pareto principle applies ruthlessly to healthcare economics.
It does. We know that approximately 20% of patients account for roughly 80% of total health expenditures. This subset of the population is consuming the vast majority of resources and is overwhelmingly defined by the complex chronic conditions, the priority conditions, the report identified. This concentrated spending represents a massive opportunity for efficiency gains.
So the final provocative thought for you to consider is this. Given that the system is a complex adaptive system, and given the crucial financial misalignment we discussed, how quickly can the health system strategically apply the new rules and the required IT infrastructure, not across the entire patient population, but specifically to that high-cost 20%? If focused efforts on that subset can rapidly generate the efficiency and quality gains required, that concentrated success may hold the key to funding the required infrastructure shift for everyone else in the system.